I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and I am here interviewing Dr. Katherine Warburton, who is the medical director of the California Department State Hospitals. And I'm going to ask her a few questions about her research in violence. One of the first questions I'd like to ask you about is we have had recent guidelines that were published by a panel of experts in the research of violence, and along with the Neuroscience Education Institute. And those guidelines were published in 2014. Since then, there's been a reported significant reduction of 34% observed in violent acts. Would you be able to comment on your thoughts in terms of those results and what you think perhaps the most valuable component of those guidelines might be for clinicians?
Sure. Well, the development of the CalVAC guidelines was really Dr. Stephen Stahl, who works on a part-time basis for the Department of State Hospitals, and he is kind of our academic guru and psychopharmacology guru. And we approached him several years ago while we were struggling with the problem of inpatient aggression and asked him to provide us with guidelines. We figured all these ivory tower people out there, they probably knew darn well how to treat aggression. And what he did is he came back to us and said, they don't exist. What you're looking for doesn't exist out there. Furthermore, you all at the DSH are the experts in treating violence because this is what you do. So I'm going to propose that you write them. So in collaboration with Dr. Morset and Dr. Stahl was kind of the mastermind. He gathered up a bunch of DSH clinicians, psychiatrists, and psychologists, and put them into different groups. So there was an impulsivity group, both for psychopharmacology and for behavioral psychological interventions. There was a predatory group for both, and there was a psychotic group for both, because we work on this typology model for aggression. So he gathered these clinicians, they reviewed the world's literature, and they put together the CalVAC guidelines. And it's one of the cornerstone components in an overarching system-wide approach to violence that we're sure has contributed to our reduction, not just in overall violence, but a very large reduction in serious violence.
That's really exciting to hear. You touched on the three major categorizations of violence that you observe for inpatient violence. Would you be able to go into each of those types for us, just for our audience, to kind of explain what those different types of violence are, and maybe the prevalence in terms of patient to patient or patient to staff?
Sure. Well, I think animal studies for many decades have dichotomized violence into predatory and impulsive or reactive. So fight or flight. There was a study in Nolan in the early 2000s that looked at inpatient psychiatric violence and really developed three categories of inpatient psychiatric violence, which included sort of organized instrumental violence, impulsive or reactive violence, and then psychotic violence. And that study was actually replicated by UC Davis, with whom we have a research partnership, and they've been collecting data on that now for 10 years. And we use that as kind of our foundational model when we look at violence. So just as an example, psychotic violence is the type of violence you expect to see when you're dealing with someone who has schizophrenia. Threat control override symptoms, feelings of persecution or paranoia, where that person's not really operating in consensual reality, is misperceiving stimuli and reacting out of generally fear. Predatory or organized aggression is much more goal-focused. It's highly associated with antisocial or psychopathic personalities, and it's got a gain. So whether it's a financial gain, has to do with the pecking order on a unit, has to do with respect or retribution. Usually it has a goal in mind, and the individual actively weighs the gain with the consequences for that behavior. And finally, there's impulsive aggression, which is a much larger kind of a catch-all. So that can be due to a personality disorder, a brain injury, a whole host of diagnoses, including the psychotic diagnoses. And that's more in-the-moment, reactive, emotional aggression. So we see less than 20% of the violence in our state psychiatric hospitals, surprisingly, is psychotic violence. That's the least common type of violence that we see. Predatory violence, unfortunately, accounts for about a quarter of the violence that we have in state hospitals, in our state hospitals. And then impulsive violence is the vast majority. So we have developed things like the CalVAC guidelines to try to understand what's driving the violence and categorize it so we can better target treatments. But we're also really trying to drill down on that impulsivity. Everything from cognitive to psychotic disorders and everything in between.
Along with the specific categorizations of violence that we just mentioned, what would you say are some of the most appropriate treatment approaches? Because they would obviously be different depending on the type of violence. And then within that, I know that there are sort of special populations, say someone with a neurocognitive disorder or someone who's experienced traumatic brain injury. How would one go about, or what would the most current research status say in terms of the most appropriate treatments out there today for different types of violence?
Well, I would refer you, I don't want to take the total punchline out of the CalVAC guidelines because that's all in there. I think we just heard Dr. Dardashti speak today at the APA about if it's a psychotic etiology, then it's antipsychotics, antipsychotics, antipsychotics. There's not a lot of treatments out there for more predatory aggression. What we're looking at the DSH is some of the risk-need responsivity modalities, more psychological modalities that target criminogenic risk factors. And impulsive, it's such a large area with so many different drivers that the treatment interventions are fairly diverse based on the driver of the impulsive aggression. So, for example, if it's a cognitive driver, you're looking at cog rehab, where if it's a borderline personality driving impulsive aggression, you're going to look more towards something like DBT. I think our speakers today highlighted the mortality risk for people who have dementia and antipsychotics, and I think they also highlighted the relatively limited data out there for TBIs, kind of as cautionary points for people looking at psychopharmacological interventions for impulsive aggression.
You touched a little bit on risk assessments for violent patients. What would you say is being conducted in terms of being able to assess what patients may or may not be at higher risk for violent behavior? Are there particular tools or assessments that you would recommend or that seem to be more predictive in assessing risk of violent behavior?
There's a whole host of different violence risk assessments, and there's everything from actuarial violence risk assessments, which are sort of using, if you think of the term actuary, very mathematical relationship between this risk factor and this outcome. And there are some actuarial instruments that have utility, but not as much in our system as what are called SPJ, or structured professional judgment tools, like the HCR V3 or the START. We employ both of those tools in our system. And those give you a much more comprehensive framework to look and drill down on various risk factors. We also have screeners in our system like the COVER, the Brosette, the DASA. So we kind of insist that everybody gets screened, and that for those individuals who are admitted because of violence or who have certain characteristics such as psychopathy, that the psychologists reach for a structured professional judgment tool, or in the case of psychopathy, the Hare psychopathy checklist. But really what we've concluded in our system is that the true violence risk assessment instrument is the psychologist. And educating our psychologists through ongoing training on all the different tools is our approach, because we want well-trained clinicians who know which tool to reach for when. But we are hoping to one day have enough data to be able to understand which of the different tools and which of the different risk factors are predictive in our population.
That sounds great. My final question is, what sort of resources may be out there for maybe novel clinicians that are just starting out working with violent patients in terms of just their safety and that type of that type of experience? What types of resources might be available for them? We know that sometimes a clinician may be assaulted by a patient, and so I would just kind of like to know your thoughts on that.
You mean like academic resources, or? And
anything that's, from psychological to academic, emotional support, anything like that in terms of just their practice and, how to cope with maybe having those types of experiences if that is their field.
In terms of resources, we have the CalVac guidelines, we have the book Violence in Psychiatry, which I worked on with Dr. Stahl. So there's stuff out there to read. What happens when a staff person gets assaulted? That's a difficult question, and really it's up to the system to try to take care of those people rather than have the staff member going it alone. I know that de-escalation training, which was kind of intervention du jour at one time, there's some suggestion that may not be effective and that it may cause re-traumatization or traumatization of people around. We do have a psychologist, Darcy Delgado, who's doing novel research on different types of post-incident interventions. And she'll kill me because I can't cite it in detail right now, but we are looking at that, of what to do in the moment and long-term to take care of our staff.
That's great. I think that's great. It's brave to pursue this career. So I just wanted to thank you so much, and we look forward to seeing you at the rest of APA. Thank you.
Thank you.